For hemorrhagic stroke, we looked at the manifestations, risk factors on the previous page. Let's just go to the manifestations and management here. So I described the three. So they are severe uncontrolled hypertension, arteriovenous malformations, and aneurysms, okay, as the risk factors for hemorrhagic stroke. Now, with hemorrhagic stroke, the main problem is intracerebral hemorrhage. So you're dealing with two things here, the stroke and the increased intracranial pressure that results. And you already know the consequences from the table previously, comparing ischemic and hemorrhagic stroke. So this will have consequences like seizure activities, for instance, and of course, increased intracranial pressure, management of which we looked at several bullet points on the previous page. Since we're dealing with bleeding here, so what's the main treatment for hemorrhagic stroke? You're actively bleeding to stop the bleeding, correct? All right. So that goes for an aneurysm, a ruptured aneurysm or a ruptured AVM, same thing. We need to stop the bleeding. Sometimes the bleeding stops on its own, but doesn't eliminate the fact that we still have to evacuate the hematoma, correct? Because that hematoma is a space-occupying lesion. So we need to open the skull and then remove the hematoma to restore normal intracranial pressure and then restore blood flow to the brain tissue. Manifestations, again, manifestations of a stroke. However, there are main differences here is the severe headache and loss of consciousness. So unlike, will these patients have a TIA? No, there's no TIA here because there is no clot, right? The rupture, did it rupture slowly? No, the vessel ruptured violently. So therefore, the bleeding is sudden, and therefore the manifestations appear suddenly. And because of the increased ICP, patient usually loses consciousness. But we still have because there is interruption of blood flow nonetheless. So there's still the visual changes, and then the arm weakness or paralysis, one side of the body, same thing. But the presenting manifestations will be the sudden acute headache and then the sudden loss of consciousness. Everything is quick. Okay? And signs and symptoms of increased intracranial pressure. So no different for the diagnostic tests, same thing. Whether it's ischemic or hemorrhagic stroke, we need a CAT scan or MRI, correct? Prevention, of course, is control of blood pressure. Now, if the patient has frequent headaches or migraines, the ideal diagnostic test is, of course, the patient has to undergo a CAT scan or MRI because these frequent headaches or migraines could be a sign of either a tumor or an aneurysm or an AVM, right? Or sometimes we accidentally discover them in the course of testing for another disorder. But for patients who have these frequent chronic migraines, they should really have at least a CAT scan. Okay, so I was just lucky. My doctor had a co-worker, so he was a fellow in NYU, and then he said he was a Filipino doctor he was working with, and the guy just dropped dead during a clinical rotation. Then they did an autopsy. He had an aneurysm. Yep. Yeah, a young, promising doctor. He was in his late 20s. Okay, he was a fellow. Huh? Yeah, and all he had was frequent migraines. So when I, reported that to my family doctor down in Florida, he said, "Oh, he called because they didn't approve it, and then you know how insurance companies are, and then he called the insurance company himself. I want this MRI, right? So he insisted, and I got it. Good results though, I didn't have any. So I'm still alive. Yeah. Okay. So the problem with and again, don't be exclusive with this one. This will be the same ideas when we get to head injury. So at least we'll go faster when we go to head injury management and discussion. So again, so this is the skull again. So inside that skull, there's brain tissue, and then there's blood, and then there's CSF, correct? So depending on where the rupture is, so let's say it's on this section right here, right? This side of the skull. So I have a hematoma there. So therefore, what will happen to the brain tissue that was supposed to be here? So a hematoma formed there, or let's say it's a brain tumor, or let's say head injury. Okay, so there's blood there. There's hematoma formation there. Brain tissue was supposed to be there. So what happened to the brain tissue? They were supposed to occupy the space. Where did they go? Okay, it was herniated, correct? So the herniation could be 4 different ways here. So there could be lateral, there could be uncal or downward, or it could also be upward herniation. So depends. How did the hematoma form? But regardless, did it shift everything? So it shifted everything. Now, keep in mind that inside the brain tissue, let's look at a picture. There are ventricles there. The ventricles of the brain contain cerebrospinal fluid. So here are the ventricles. Okay, so just like the ventricles of the heart. So these are ventricles that contain CSF, and then in between, of course, the CSF circulates and then drains eventually into the spinal column, right? So let's say you have a hematoma right here, a large one. So that means all this brain tissue here has to make way for that hematoma, correct? So everything will be squished here, and then unfortunately the brainstem will be pushed out into the foramen magnum, this opening right here. So you see what I mean? These are big, it's a big mass of brain. Then you force that into this narrow opening. Of course, that will be ischemic, correct? There's incarceration there. It'll be strangled. And meanwhile, what happens to the normal drainage of your CSF? Because you pushed everything toward the other side. Do they still drain normally? Meanwhile, CSF production continues, but they cannot drain. So what will happen? Okay, so will you have hydrocephalus? Yes, the patient develops hydrocephalus, and then that contributes to the increased intracranial pressure. So when we get to head injury, there are about 6 secondary injuries, and we'll talk about those. They also apply here in hemorrhagic stroke because it's like brain trauma, right? So there will be up to 6 secondary injuries, meaning this first injury that the patient sustained, the lack of blood flow to the brain, is not the last of their problem. So that's just the primary problem. They will develop up to 6 secondary problems because of that hematoma formation there, right? So it's not here. We'll discuss that when we get to brain trauma. Okay, let's talk about cerebral hypoxia and decreased blood flow. So this is one of the complications. I might as well discuss CPP here now. Okay, so let's go to whiteboard. I'll try to draw with a mouse cursor. I'll try. cerebral perfusion pressure. The formula is MAP minus ICP. CPP should be between 70 to 110 millimeters of mercury. Okay, so pressure. So cerebral perfusion pressure ideally should be between 70 to 110 millimeters of mercury. The formula to calculate this is mean arterial pressure minus intracranial pressure. Let's see what happens if, what's the normal ICP? Some books say 10 to 15, some books say 0 to 15. But the concern really is high ICP, not necessarily low ICP. Does that make sense? Okay. So if our limit is 15, so let's say after hemorrhagic stroke, it rises to 20. And let's say the patient, because the patient had a rupture of brain tissue, and let's say this is Kurt. All right. So what's your blood pressure, Kurt? Okay. So let's say 110 over 60. What is the MAP? 110 over 60. Still remember how to calculate MAP?
76.6.
Okay, so 120 plus 110 divided by 3. Isn't that 90?
No.
Because it's 2 times diastolic, 120 plus SBP, 120, 230 divided by 3, 76.6.
Yeah.
Okay. What is your answer? How is your CPP? If your CPP falls below 60, brain cells start to die. So, do you want your blood pressure to be normal after stroke? No. What do you want this blood pressure to be? We don't want a normal blood pressure. We want a high blood pressure. As long as it's, no, less than 185 over 110. Okay, as long as it's less than 185 over 110, you're good. Okay, but we don't want it normal. We don't want a normal blood pressure. With head injury, with stroke patients, we want the blood pressure to be high because of this formula. Do you understand? That's good. All right. Yeah, the higher, the better. But as long as it's under 185 over 110. But in practice, again, follow your neurologist's limit, okay? Because some neurologists will have different numbers. Sometimes they don't want it 185, they want 180 over 110. Varies. Okay, but you, meanwhile, as a nurse, okay, you're so concerned, like, that blood pressure is really too high, okay? And then you just keep talking to somebody, okay? Just tell one of the doctors, somebody will eventually listen to you. The problem comes, remember, there's a cardiologist here, correct? Yeah?
Yes.
Okay, so the cardiologist and the neurologist both work on the patient. What do you think the cardiologist's goal is? Because the patient has a cardiac problem. Does he want the blood pressure to be high or low? Low. So sometimes there's a conflict here. So you see who, depends on whoever, which one came to see the patient first. So here comes the cardiologist, comes in, orders metoprolol, blah, blah, blah. And then, yeah, wants the blood pressure low, right? And then here comes a neurologist, comes in, sees the order, DCs it, right? Discontinue metoprolol, right? Yeah, this is dropping the patient's blood pressure. So let them have at it. But just make sure your patient is fine, okay? So just make sure this is your priority, right? Because it's brain tissue. So we need to keep the CPP at least 70. So if we can get away with it, so give me a minimum blood pressure to keep this to keep this number to 70. I mean, 60, technically the brain cells are alive, but if this is your mom, do you want your CPP to be 60 for your mom? No, I want it at 70, right? 60 is like asking for, it's too close. Brain cells will die if once it drops below 60. So remember, it's not easy to drop that ICP. Is it? I mean, with a very, rigid environment like the skull, it's not easy to drop the ICP. It's gonna remain. I mean, can you lower the swelling after a stroke? Can you, it's not easy, right? Yeah, it's not easy to drop the intracranial pressure. It's easier to manage the blood pressure. It's easier compared to the ICP. So you need the blood pressure to be at least, what about, let's try 140 over 90. 140 over 90. What's your MAP here? 180 plus 140, 330 by 3, 110, right? Oh, 110? Okay, so that's great, right? So you want it higher, right? We never want a normal blood pressure. So don't fall for this. On an NCLEX question, for instance, you see options that say, okay, drop the blood pressure. Nah, not for stroke and head injury patients, okay? So this is an exception, okay? So this is one scenario, one disease condition wherein we're happy with a high blood pressure, right? Okay. Yeah, this is an exception in our usual care. So here are your interventions again to maintain blood pressure. We want the adequate hydration, so don't wonder why did the patient order fluids. Okay, it's to maintain a high blood pressure. Okay, so we want of course we don't want blood pressure to be too high either. Definitely we don't want it normal or low. Okay, we want it to be moderately high. And watch for seizure. Remember the 5 seizure precautions, your activities from last semester. So what are the 5 seizure precaution activities for the nurse? You set up what? Suction, what else? Padding, oxygen, IV access, and the bed must be lower. Okay, so don't forget the 5 seizure precaution activities. You'll see these will be familiar when we get to head injury. So let's just go down the list. So increased ICP, again, expected because of the bleeding. The space occupying hematoma will increase ICP. And then CSF will now increase also because, again, of the herniation. Okay, so the normal drainage pathways of your CSF is blocked. Now you have increased, you have hydrocephalus as a result. To manage this, we can do 2 things. 1, the doctor may drain the CSF. To do this, the doctor will insert a intraventricular catheter. Intraventricular catheter, IVC. Now, there are 2 purposes of putting the intraventricular catheter. It has 2 purposes. One is to monitor pressure, because otherwise can you measure the pressure inside the brain without an invasive tool? No. Okay, you have to put something in there. So the catheter will do that, but it serves 2 purposes. It does not only monitor pressure, it can also be used to drain CSF if needed. So remember, the CSF has to come out. Right now it can't because its pathways are blocked because of the herniation. Okay, that space occupying mass, the bleeding is shifting everything. So it's blocking the ventricles and the drainage pathways. So that's one way. Another is to give mannitol. This is an osmotic diuretic. How it works is it absorbs water from the extracellular space as well as from the intracellular space into the bloodstream. Again, yes, so you give the drug intravenously, it will pull water out of the brain cells and also out of the interstitial spaces, including the CSF. It will pull it into the bloodstream and then takes it to the kidneys for elimination. All right. The drug though has to be drawn. Yes, ma'am. Yeah, is this all part of the injury? So whenever a tissue, let's say it's the same as, let's say you get a wound, right? So what happens to the surrounding tissue after you sustain the injury? Everything swells up. It's part of the inflammatory response. So same thing as if a blood pressure, a blood vessel ruptures, such as in hemorrhagic stroke, it even does it in the stroke. Remember stroke, earlier ischemic stroke? So once the tissues die, you got dead tissue, everything will swell. So same thing. It will cause inflammation, and then there's always, why did the tissue swell? Because there's increased fluid there, right? Leaking. The capillaries were leaking fluid. That's why, a pimple, let's say you pop a pimple, swells because the capillaries became leaky. Okay, so that's what's happening. What we're trying to eliminate here. So when you give mannitol, that's what it will do. It will pull water and then eliminate it. Okay, so controlling your ICP. But obviously, can this do it alone? No, but it's help better than nothing, right? So we make sure though that the blood pressure doesn't drop too low, because mannitol, it's an osmotic diuretic, but it's still a diuretic. So therefore, what will any diuretic do to blood pressure? It's gonna drop it. So make sure the blood pressure is high enough for mannitol administration. So here, it pulls water out of the brain tissue by osmosis, and then promotes diuresis. Now, another thing to remember is, I was saying when you draw up mannitol, so it comes in a big bottle, right? In a big vial. When you draw it up, whenever it exposed to air, meaning the atmosphere, which happens, right, during water displacement, when you draw it up into a syringe, there's air, right? So when it mixes with air or exposed to air, it forms crystals. It's just a natural reaction. That's how it reacts to the atmosphere. So when you take it out of the vial, it will form crystals. So therefore, what should you draw it up with? So you can strain those crystals, those microscopic, a filter. Okay. So there should be a filter needle. So as you draw it up, knowing it will form crystals, use a filter needle. Are we clear? Because otherwise you'll be infusing emboli. Those crystals are emboli when you become emboli when you administer it. Okay, so it's talking about head of the bed elevation. Remember those bullets we talked about earlier? Okay, so they're all mentioned here again. Okay, hypertension, yes, this caused the bleeding in the first place. No, it contributed to the hemorrhagic stroke. But again, after the stroke, do we want the blood pressure to be low though? Okay. So here's our goal again. So the blood pressure should be between 150 to 220. I would disagree with the 220. That's too high, right? So at least 150, that's good, right? Or better, 140 would be our goal. But under 180. This is what I mean by some doctors, like I've had a resident wherein my patient's blood pressure, my stroke patient's blood pressure was 185. And he kept insisting, oh, that's fine. I had to call somebody else because there's no point talking to the same guy, right? He already said no to me. So I asked somebody else, and that guy gave me because there are residents. Okay, there's a first year resident, there's a second year resident. So you just try your luck, right? So that's what you do. You don't like this guy's opinion, so you talk to someone else. Okay? No need to make a conflict, right? So these are the common drugs: labetalol, nicardipine. So your patient, William Price, will have labetalol ordered as needed. Hydralazine, Hydralazine is also a good, this is a vasodilator. It's a effective drug you can give IV. Nicardipine obviously is a nicardipine is a calcium channel blocker. We were here, right? Okay, yeah, mannitol. Okay. And hydralazine. So all of them basically, dilate blood vessels. If you look at the mechanism of action, all these drugs dilate blood vessels. They lower blood pressure. Again, watch the blood pressure. Don't over medicate. Okay, we want the blood pressure to remain high. If the patient does have bleeding, because they were on anticoagulants, for instance, then these are the reversal agents. You can give plasma or vitamin K, whatever the drug we're trying to reverse. So the antidote would vary, of course. And then here's the last thing. If we can't control increased ICP by any other means, then it'll be surgery. Remember craniectomy? Okay, so they'll remove the the skull and then leave it open to relieve the pressure.
When they remove the skull, did they keep your skin? They put it back?
Yeah, they stitch the scalp back on, and then the skull will be placed somewhere in your abdominal wall.
What's the purpose for that?
They call the procedure marsupialization. You know what a marsupial is? A kangaroo. Like a kangaroo has a pouch. Okay, so they put the skull somewhere in your abdominal wall, like a marsupial. Okay, so since it's, yeah, so it's recognized by your body as, oh, this is my skull. Okay, so they'll grow blood vessels to feed it, so the skull will remain alive. Okay, as long as you keep it in your body, so it'll be recognized. Oh, how'd you get here? The body will say something like that and then grow blood vessels. Okay, here, I got you, buddy. Then we'll just take it back out and put it back on. Yeah, whenever that time comes. Okay, so we'll stop here. We'll continue with